So I want to ask you something before we start. So think about your knees and hips, the joints that carry you around, helping you do all the things you want to do. Now ask yourself honestly, do you know how healthy they are? Not whether they're hurting right now, but whether they're in good condition, whether their age compared to you is appropriate. Are they drifting quietly to a problem that you can't feel yet, or are they going to last you longer than you need? So most people have no idea, but it's no one's fault. It's just people haven't been taught correctly how to assess their joint health and their joint age. In this video, I'm going to change that. I'm going to tell you my story, including the parts I don't usually share and haven't before. I'm going to give you a complete framework on how to protect your joint health, prolong their lifespan from the knowledge I've developed over 25 years in the field of orthopaedics and for over a decade now as a consultant orthopaedic surgeon in the NHS and in private practice in London. By the end of this video, you're going to understand why most joint problems are preventable, why a scan alone doesn't tell you what you need to know, and what you can do starting this week to improve the trajectory of your joint health. Stay with me, this one matters. So I want to tell you something that I don't normally share. I want to tell you my own personal story because I think it really matters, and I think it will help you understand why I do things differently to many of my colleagues at present. So I'm 49 years old at the moment, 50 next year. My father died when he was 50. My grandfather died when he was only 42. I've got 4 children, I'm very blessed, but the youngest 2 are 2 years old and we have a 3-month-old baby. Most of my adult life, I didn't really care too much about my health. I didn't eat very well, I had a lot of processed food. I used to go out a lot, I was very social, I used to drink a lot of alcohol. I was relatively overweight. Maybe last year I weighed over 100 kilos and I'm about 5'10". I did some exercise, I used to play a lot of football, but over the years the exercise stopped and I would spend more time, I guess, maybe watching TV and movies, on my phone sometimes at night, not a lot of sleep, sometimes a little bit stressed due to the pressures of training as a surgeon, trying to make it to the top of the career, and also the pressures that come with working as a surgeon in the NHS and in private practice. So I probably wasn't looking after myself too much. I had learned most things about joints, about joint health, about strength, surgery, inflammation, biology and physiology of how the body works, but I wasn't really practicing it myself. Then something happened that changed everything. My daughter Coralie was born 2.5 years ago, extremely premature, weighing only 700 grams. She had significant health issues, had to have multiple major surgeries, and we were told she would have a very different life in terms of she would have major learning difficulties and issues taking in nourishment and food. I watched her really battle for her life and realised very quickly that I needed to be there for her and for my other children, and now was the time to make a change. So I enrolled in the London Marathon for the following year, got lots of sponsorship, was kind of hoping I could back out, but it was too late because everyone was sponsoring me. I managed to drop a lot of weight and start running. I wasn't a runner, I used to run maybe couch to 5 kilometres, and I ended up doing the whole marathon without stopping. The time wasn't particularly fast, but during the training over the 6 months that I trained, I ended up picking up quite a lot of pains that lots of my patients get. I would get hip pain, that would be trochanteric pain syndrome. I got pain at the front of my kneecap, which is called runner's knee or patellar tendinopathy. I got shin splints, which is also called medial tibial stress syndrome. I got some plantar fasciitis, where there's some pain and inflammation on the sole of the foot. I also got pain in my Achilles tendon called Achilles tendinopathy. I didn't have surgery or injections for any of these ailments. I trained them away with strength training, good nutrition, progressive loading of the tendons and muscles so they could cope with the demands I was putting them under. I slept well, I tried to reduce my stress levels, and my pains went away. I got fitter and fitter and completed the marathon with no problems, while I saw many runners around me all having various injuries, and these were very fit people and some not so fit like myself at the time. So I now weigh around 80 kilos. I'm in the best shape I've been for probably about 20 years. I go to the gym at least once a week to do heavy lifting, especially for my leg muscles, and that's all I tell my patients they need to do. I still enjoy going out occasionally when we can. It's difficult now, obviously, with 2 very young children, and I sometimes have processed food. I still enjoy like a pizza, the occasional beer, but that's fine. I think everything in moderation is fine. It's important that you know that you don't need to make huge, unsustainable changes. You just need very small changes that progressively will compound and help you in the next 5 years, 10 years, 15 years and 20 years. So I've been an orthopaedic surgeon now for about 25 years and a consultant surgeon for a decade now. I've done thousands of operations on knees and hips and broken bones, fixed ligaments in knees, done advanced minimally invasive hip replacements, robotic knee replacement surgery, lots of repairing of meniscus tissue in the knee and various defects of cartilage. The overwhelming majority of my patients that I've operated on, fortunately, have done really, really well and have got back to function. Occasionally some patients have had complications, as is the risk when we undertake surgery, and then I've done my best to get them back to fitness again, either with further procedures or with other methods. But what I've really realised is most patients get to me probably too late. They spent months, sometimes years, with pains or injuries or undiagnosed joint problems, moving between different types of health practitioners who work treating musculoskeletal ailments. So if you have a problem with your knee or hip, you might see a physiotherapist, an osteopath, a sports medicine doctor, a GP, a rheumatologist who's a doctor who looks after diseases that affect the joints. You may also see a personal trainer in your gym, a strength and conditioning coach, or a sports rehabilitator. So it can get really confusing as to who to see. Often these professionals, including orthopaedic surgeons like myself, practice quite differently to colleagues. We all have our own way of practicing based on our own beliefs and our training. And what you'll find is often these practitioners hardly ever learn from each other or watch each other work. So when you train as an orthopaedic surgeon, you learn medicine in university, and then you train as a surgeon in many areas like vascular surgery or plastic surgery, and then you fine tune into one branch of surgery like orthopedics. You do the whole body, and then you start to focus down onto an area. So I focused mainly on knee and hip problems. The thing is, during my training, I didn't really learn anything from physiotherapists. I never saw an osteopath. I didn't know what a sports scientist was, and the pathway between me and a sports and exercise medicine doctor is totally different, so our paths very rarely cross. So we all kind of learn in silos. We don't learn from each other traditionally, and when patients see us, they see us separately as well, and often get caught in the middle if we aren't sure what the diagnosis is, or if we have different ways of treating the same problem. I found the model was wrong, and also patients and practitioners were relying too much on scans like X-rays and MRI scans, which are really helpful, but they're just snapshot pictures of structure. They don't necessarily portray the biology of what's going on in your body, or they don't necessarily show pain or often inflammation on a cellular level. So they don't really give you the answer, and I feel lots of practitioners don't quite understand that. To be honest, it took me many years to figure that out. And that's because some patients who have fairly significant looking x-rays and scans don't feel much pain if they have lots of arthritis in their knee, whereas other patients may have very small defects in the cartilage and they are really disabled by it. Studies have shown that most people over the age of 50, if imaged, will have a degree of wear and tear in their joints, in particular their knees and sometimes their hips. Most of them have no pain at all, and the reverse is true. I've met lots of patients who have significant pain and the scans look relatively normal. So pain is mainly affected not really by structure but by inflammation. This is how well your body processes energy and manages blood sugar. So you may have heard something about insulin, which is a hormone that helps regulate blood sugar. People who are very resistant or have cells that are resistant to insulin often will have some type of diabetes. And so what you want is to be sensitive to insulin, and you want to have relatively low blood sugars. So when your blood sugars spike, the insulin can help control the level of sugar in the body, and by default control the level of inflammation. Inflammation is also affected by stress and by sleep. Less than 7 hours of sleep a night has been associated with a rise in something called cortisol, which is again a hormone in the body that affects inflammation. Stress also increases your inflammation because of the stress response. Body weight is important, but what's more important is body composition. So lots of muscle is very protective for you, And muscle is so important, more as we age than when we're younger, because as we age, especially for women who are postmenopausal, muscle mass reduces significantly each year if you don't do anything to support it. Fat and having lots of fat in your body or being overweight in terms of adipose tissue is not a good thing, we know in general, but not just because if you're heavier, more force goes through your joints, but also because the fatty tissue is very pro-inflammatory and makes you more sensitive to pain. So reducing the fat on your body as best as you can and increasing the muscle in your body, in particular in your legs and in your bum, your thighs, your calves, really help you. So none of these things appear on MRI scan and an X-ray, and that is why I've created the concept of orthopedic longevity or joint longevity, or what we call OrthoLongevity. So OrthoLongevity is a framework I now use on every patient that I see, whether that's in the National Health Service, where there are constraints but I still do my best to do it, or in private practice where it's a little bit easier because I get a little bit more time with patients and I have a little bit more resource available to me. It combines everything I've learned over 25 years being involved in orthopaedics, but also combines the best of the disciplines of physiotherapy, osteopathy, nutrition, functional medicine, which helps with sleep and stress and overall metabolic health, sports and exercise medicine, and radiology. The practical framework has 6 steps, and to make it easy to remember, we call it R.E.P.A.I.R. That's R-E.P.A.I.R. Each step builds on the last step, and surgery, even though I'm a surgeon, comes in at number 5 if it's needed. So R stands for reset biology. So what does that mean? It means before we strengthen, before we inject or even consider surgery, we want to reduce the inflammation and make you biologically optimized to heal so your joints can mend. So we want to improve your insulin resistance or assess it. We want to make sure the vitamins and minerals in your body are optimized and you're not deficient. We want to help you sleep better or figure out why you're not sleeping. See, we can help manage your stress, though I appreciate that's very difficult to do when we all have real life pressures like work or family or financial. But there are ways that we can help you think about these things in a way that's more productive and less stressful. Nutrition is important, and we can give you practical tips on how you can improve your nutrition in a real life way that you can actually do, not sort of cooking really difficult food or buying expensive produce that maybe isn't sustainable, but real world ways, small changes you can make to improve nutrition for yourself and your family. Habits that you can keep for years to come. This is so important because having good biology helps you avoid surgery, but also if you need treatments like injectable treatments like PRP or surgery like a total knee replacement, you are going to do so much better if your biology is set well. It's a bit like gardening. You want to fix the soil before you plant, and that means if you plant afterwards your seeds, it's going to do so well because the soil is ready. So we want to optimize your soil. E stands for enhance movement. What does that mean? Well, before we put a joint under load, we want to make sure it's moving well, that it's not stiff, it can move as best as it can, and we can try and help that, and that the joint is stable, so the ligaments, tendons and muscles that hold the bones together are doing their job and can't be optimized any further. This step's normally done with the help of our physiotherapy and osteopath practitioners that work alongside us to understand how you move when you're doing normal everyday tasks, how you move if you're trying to do higher level tasks like sporting activities, and to see whether you need any targeted strength training or stretching, or even postural correction or physical manipulation and advice on gait and stance, how you sit, how you lift, how you move. You've got to move better before we start loading the joint more. The third step, I think, is one of the most important ones, and it's P for power. So I think it's the most powerful step. We need you to get as strong as possible once we've optimized your biology and we've got you moving as best as you can. And that's normally with our strength and conditioning coaches, our personal trainers and our sports scientists. Strength isn't just exercise, it's actual treatment. And strength training doesn't mean going for a walk, going for a cycle, swimming, doing yoga or Pilates. All of those activities are excellent activities, and I commend you if you do them, but they don't really help much in terms of preventing joint pains, prolonging the life of your joint, or helping you rehabilitate from injury or from surgery. So the key here is, once you're in a good state, is to do strength training. Now for me, the basic training that I do just once a week in the gym for about 1 hour or 1 hour 10 minutes is about 8 to 9 different exercises on my leg muscles, and I've made another video on this which you can look at if you look at my channel. And I tend to do 6 repetitions of each exercise 3 times, so 6 repetitions of each exercise 3 times, and after I do the 6 reps I normally have a 1 to 2 minute break so I can kind of get my strength back. There's many ways you can train, but for me in general, low repetitions, slightly higher weights, and each week or each couple of weeks you'll find, if you log what you're doing, and I tend to use an app to help me do that, but you can use a pen and a pad if you want, you'll find you can just push up the weights that you're pushing every so often a few kilos, which means that you're getting stronger and stronger. But again, our program has been designed, it's multidisciplinary, by strength coaches who their whole field of study is to help grow muscle. Strong muscles are important because they help cushion the joint, they help protect the soft padding in your joint, whether it's your knee or your hip, and that would be articular cartilage, which is the sort of thin, slippery layer that caps the ends of the bones. And in your knee and in your hip, you've got extra cartilage called meniscus or labrum respectively, which are rubbery circular structures that also help cushion the joint and help it dissipate force and load. What's A stand for? A stands for Augment Healing. What does that mean? Well, this is where I've moved a lot more into biological treatments and certain injections in the last few years than I ever did. I was taught that platelet-rich plasma, which is where we take a large volume of blood from you, normally about 60 to 90 mils currently, or we can take smaller doses, but we would then give you maybe 3 injections spaced every 2 to 4 weeks. But essentially we take blood from you, we spin it in a special machine so it separates the components of your blood into different layers. We extract the layer that has all the growth factors and healing proteins and platelets. They're all the things in your blood that help you mend every day. And we put that concentrated shot normally into your joint, normally your knee joint or your hip joint, or a tendon or an injured structure around your joint like a meniscus or a labrum. And we believe that this good biology can help stimulate your body to try and mend itself. And it's been associated with really good results if you take a good enough volume of blood, process it properly, and you inject it normally very precisely under ultrasound guidance, which is what I do, so we can see exactly which structure we're injecting into. And it helps if the patient does their strength training, has got good movement, balance and stability, and also biologically they're as optimized as possible. So altogether this helps. None of these things work that well in isolation, but platelet-rich plasma is a very good biological injection. Other things we can inject that can also help is hyaluronic acid, which is a gel that can help reduce friction, especially in knees that are sort of catching a lot from cartilage tears. We can also inject something called Arthrosamid, and I'll be doing a video on that in the next few weeks, which is a very thick injectable gel that helps the inner lining of the knee reduce its inflammation, which means that you don't feel as much pain, and it can often act also as a bit of a thick sort of shock absorber within the knee that can help reduce pain in severe osteoarthritis. We can also inject corticosteroid, which has been around for years. It's fairly controversial because some believe it can have a negative effect on joint health, but I feel it does have a place. It's a very powerful anti-inflammatory, and if you're in pain, you've got a very swollen joint, it's very good at getting you out of pain and getting you back to rehabbing. So those are the 4 types of injection I would normally do. And again, I've got a good video on injection types which you can watch on my YouTube channel. So what does I stand for? I stands for what I tend to do as a surgeon, intervene surgically. So as you can see, I normally only reserve surgery for people that are not progressing with non-surgical options or are getting fed up, or if they have significant injuries, where very rarely, sometimes we have to go straight to surgery. And the surgery we do again is normally augmented with the patient being biologically optimized as much as possible, having the movement, the maximum movement and stability they can get, and also potentially using biological treatments like platelet-rich plasma as part of the surgery as well to help repair. So if I do a repair of tissue called meniscus in the knee that often tears, or even the anterior cruciate ligament, if I do an ACL reconstruction or repair, I'll often use platelet-rich plasma injections to help augment that surgery to help the patient get a better result. And only about 10% of my patients need surgery, and of them maybe 95-96% get excellent results. So it does work, and when needed we'll absolutely do it. We use the latest techniques as well. Not to forget, after surgery rehabilitation is important, and that's why the team I work with and the method we have with OrthoLongevity is excellent. It's a team approach. So we have physiotherapists initially to help get the swelling down and get your movement back, then osteopaths to help you with any manipulation or physical treatments that you may need if your posture needs improving or your gait and stance has been altered from the surgery. And then once you're fitter, we get the strength coaches and the personal trainers to get you strong, along with nutritional support, because you need lots of nutrients after surgery because you're normally in a state of breakdown called a catabolic state. So you need lots of vitamins, minerals, you need fluid, and you need lots of protein as well, so they can help with that. So we talked about R.E.P.A.I.R, we've done R.E.P.A.I. What's the sixth one? It's R again, resilience. So what does that mean? Well, this is something I feel healthcare generally still ignores, especially in government type systems. So once the acute problem's sorted, we need to make sure that your joints stay healthy for life and you don't get the problem again. And so it's important you keep going to the gym, you keep doing your strength exercises, you're able to eat well, keep your nutrition up, reduce your processed foods, increase your anti-inflammatory foods, ensure that you manage stress well and that you sleep well for life. So the key is we need to make changes that are easy for you to adopt, because I've been there, I've made changes that I've done for a few months and I just couldn't keep up with them and I've fallen off the wagon. So we have a system in place which I think is a real world system that has small little incremental changes that will make you get into really great habits that are going to maybe not show themselves immediately but eventually pay off for years and years. Think of it a bit like investing, but instead of in money you're putting a little bit away for your health, which is going to be amazing for you as you grow older and for the family around you. So to close, one of the biggest problems I see around me is time wasted. Patients moving between different types of practitioners who look after joint pain, getting conflicting advice, having care that isn't joined up where the practitioners don't talk to one another or don't even know each other. So that's what OrthoLongevity is here to diagnose early, to treat in a framework with a defined order that's multidisciplinary and has all the specialities having input. It's at the moment surgeon led, as the surgeon has oversight of all the possible treatment options, but it could be led by any of the practitioners mentioned. We want to fit you up with the best care possible and the least invasive care, but we also don't want to waste time. So if you need like level 3 care, so if you need an injection, we don't want to delay you too long. But likewise, we don't want to offer surgery too early if there are other ways to treat you. Your scan, just to remember, it's not your destiny. Whatever it shows or whatever the report comes back, it doesn't mean that you're that label. Your joint's future is also not fixed. There's almost always more that can be done than you've been told. And alongside the clinic, I'm also building a digital tool so people can access this type of healthcare regardless of where you are, because sometimes the type of healthcare I've talked about at the moment is only reserved for those in elite sports, celebrities, people that can afford to have a multitude of different types of specialists all working together for them. And I've been looking at ways to make this work in terms of health economics so we can give everyone a similar level of care. So we're building the OrthoLongevity app so that anyone anywhere can start tracking the health of their joints. We're starting it with knee health first, and we've got a tool at the moment that you can use that will give you an estimated score of your knee joint health and your knee age as compared to your current age. So it may be that you're 58, but if you're doing really, really well and you're doing all the right things, your joint health may be 38. So it's going to give you the biological age of your joint every week based on what you've been doing that week, and you can keep a track of how you're doing. So you don't need to be my patient and you don't need to be in London to benefit from this. And if you want to hear more or have a go at doing the knee score that we have, then log into ortholongevity.ai. The link will be in the description for this video, and it's totally free as well. If you'd like to find out how OrthoLongevity can help you as an actual physical patient, then of course you're very welcome to come and see me in London at the Lanserhof Clinic in Mayfair. Leave your questions below. I read all of them and answer all of them. Thanks so much for watching. Take care of your joints. They're really worth the effort.